Today's speaker is Dr. Joe Duffy. If you Google Dr. Duffy for looking at what publications he's had, for example, you will learn that he is an Irish retired mixed martial artist who competed in the lightweight division of the Ultimate Fighting Championship. But we know him better as a professor emeritus of speech pathology and a practicing medical speech pathologist at the Mayo Clinic. He has an extensive resume with over 200 publications on focusing on the neuropathologies of speech and language. He's known as the author of the textbook Motor Speech Disorders, Substrates, Differential Diagnosis and Management. And he's also one of the authors of the apraxia of speech rating scale that many of us use in clinical practice and research practice, certainly. So today, Joe Duffy is going to talk about primary progressive apraxia of speech. What is it and what is it teaching us? And I'm happy to give the floor to Joe.
Thank you, Dirk, for the introduction. I will say that my fighting days are over. I really appreciate the opportunity to contribute to this lecture series, which is really excellent. I'm going to be talking about primary progressive apraxia of speech and reviewing a number of things about it. I have a few disclosures that I'm not going to review in any detail here. You can look at that as you like. Much of what I'm going to talk about today comes from the work of our research team, and I'd like to acknowledge my colleagues. This is a multidisciplinary effort, including neurology, neuroimaging, speech-language pathology, and neuropsychology. And we've been doing our work for 10 or more years now. So much of what I'll talk about today tries to pull together what we have learned. Just to whet your appetites for the topic, for those of you who are not familiar with progressive apraxia of speech, let me play you a brief sample of a patient who has the disorder. Please listen to the content of what he says, but take note of the features of his speech, particularly the prosodic features.
To participate in research directed at speech problems, specifically the research is to show that speech problems can occur in isolation of other neurological problems.
All right, so with that introduction, and please tuck what you just heard away for a while because we're going to return to that patient. By way of overview, I'm going to talk about neurodegenerative apraxia of speech as a primary manifestation of neurodegenerative disease, and we call that PPAOS. We'll discuss the relationship of it to primary progressive aphasia, review some demographics, talk about its clinical features and neuroimaging correlates, how it evolves over time. We'll say a few words about the underlying pathology and the possible mechanisms of action and their implications for how we understand the neural control of speech production, beyond what we've learned from stroke-induced apraxia of speech. Why is this important? Well, first, PPAOS, or progressive apraxia of speech, is a devastating disorder relative to communication, and it's typically a precursor to more widespread problems. Historically, it's been under-recognized and often misdiagnosed. Interestingly, it predicts the underlying pathology, and that has implications for medical treatments when they become available. And affected people can be helped today. I'm not going to be talking about management, although I'll be happy to answer any questions that people have about that at the end. Another reason it's important is that it gives us another window on the brain's control of speech planning and programming. Most of what we understand about apraxia of speech comes from patients who have it because of stroke. And that means that the characteristics of PPAOS may or may not be identical to those associated with stroke-related apraxia of speech. And that by studying progressive apraxia of speech, any differences we find might broaden or alter AOS diagnostic criteria. It also gives us an opportunity to examine other ways in which speech planning and programming can break down. What is speech programming? Basically and very simplistically, speech planning and programming is what organizes and packages complex movement instructions that directs the actions of muscles and structures that have to move to produce speech. And this occurs at the interface between language formulation and motor speech execution. And if we're talking about disorders, it occurs at the interface between aphasia and dysarthria. So a very basic definition of apraxia of speech in general is that it's an impaired capacity to plan or program sensory motor commands that direct movements for speech. And like aphasia, this is usually localized to the left hemisphere. The current consensus about apraxia of speech is that it has both articulatory and prosodic abnormalities as primary features. And we'll talk a little bit about this, more about this later. Progressive apraxia of speech is apraxia of speech of insidious onset and gradual progression because of neurodegenerative disease. And it very frequently occurs with aphasia. And in neurodegenerative disease, that is primary progressive aphasia. Primary progressive apraxia of speech is PAOS, in which apraxia of speech is the first, the only, or the most salient feature of disease. There's no aphasia early in its course, and often for an extended period of time. And the person with this disorder does not meet criteria, diagnostic criteria, for any other neurologic disease diagnosis. So, where has this problem been hiding? Well, it's frequently misdiagnosed. We see more than a handful of patients who come to us with a diagnosis of a psychogenic disorder. Many patients are felt to have had a stroke, even without evidence of that. Some patients come with a diagnosis of ALS or Alzheimer's disease. More than that, though, it seems to be hiding in plain sight. And by that, I mean under the heading of primary progressive aphasia. If we look at the current consensus criteria for the diagnosis of PPA subtypes and focus on the nonfluent or agrammatic variant of PPA, the core features required for its clinical diagnosis are that it has to have, a patient has to have a grammatism in language production or effortful or halting speech or apraxia of speech. Patients have to have one of those two characteristics. And they have to have at least 2 of 3 additional features: impaired comprehension of syntactically complex sentences, or 2 normal abilities, meaning spared single word comprehension or spared object knowledge. Now, if you think carefully about these criteria and how they're laid out, what this means is that if you have a progressive apraxia of speech, but no agrammatism in language production, you do have one of the core features, and only one of them is required for diagnosis. If you also have spared single word comprehension and spared object knowledge, that means you can get a diagnosis of nonfluent or agrammatic primary progressive aphasia if all you have is apraxia of speech. So there's some logical inconsistency to that, but it does suggest that this is a place where primary progressive apraxia of speech, or at least progressive apraxia of speech, is hiding. The median prevalence of apraxia of speech across numerous studies of the agrammatic variant of primary progressive aphasia is 78%, and the range is upwards of 100%. In our own research cohort, and these data are a little bit old, 23% of our cohort of patients with any variant of primary progressive aphasia or primary progressive apraxia of speech had the non-fluent agrammatic variant of PPA. 85% of those patients had apraxia of speech, and the apraxia of speech was worse than the aphasia in 65%. In addition, 18% of our entire research cohort had primary progressive apraxia of speech, meaning no aphasia at the time of presentation. So this basically means that progressive apraxia of speech, or PPAOS, probably is not as uncommon as the literature might imply. More recently, there's been general acceptance that PPAOS is a distinguishable neurodegenerative condition. And relative to primary progressive aphasia, it's been concluded that motor speech deficits are almost universally the most salient feature in the non-fluent variant of PPA, and that the cardinal clinical feature in the non-fluent variant is a motor speech impairment consistent with apraxia of speech. So again, there's still some logical inconsistency here in that a variant of primary progressive aphasia exists in which the cardinal feature is not aphasia. So let me just present a few brief case samples to give you some sense of this problem and some of its variants. This gentleman in this first clip is 6 years post-onset of primary progressive apraxia of speech. His difficulties began at age 48. And note the characteristics of his speech, and I think you may agree that one is most struck by the phonetic or articulatory difficulties that he's having. He's describing the picnic scene from the Western aphasia battery.
Well, young boy is flying a kite. His dad is running behind him. There's a girl on the beach making a sand castle, and the guy in the dock catches first. Their young couple after a picnic, he's wearing a buck. Artillery.
Stethoscope. And once again, there was no evidence of aphasia at that point in time. Here he is at 8 years post-onset, and I think you'll agree that he is having some difficulty with grammar. If you listen to the strained features of his voice, you will probably agree that he also has a spastic dysarthria at this time. And the worsening of his apraxia of speech is evident.
Find a cat, sample in the bar, cheese, fag, fan, and driving.
Artillery. Stethoscope.
section called schedule.
Choosing that.
Although aphasic at that time as apraxia speech clearly and unambiguously dominated any difficulties with language. Here he is at 9 years post-onset. He is using an electronic device to generate speech. You'll note the agrammatism and what he composes, and that his dysarthria is considerably worse, although apraxia speech still dominates. Anything else?
Hawaiian dog finding a kite. Man and woman on picket. Man fishing on dock, little girl boating Santico.
All right. Artillery.
And here he is at 10 years post-onset with much more significant difficulties. Voice is very strained, clearly spastic, but the features of his, some of the features of his apraxia speech are still quite evident. And he passed away during that year. The underlying pathology was tauopathy that was consistent with cortico-basal degeneration. This is a woman, a 60-year-old teacher who is 9 years post-onset. She had an initial diagnosis of a conversion disorder. She'd been unable to work for 4 years. At this point in time, 9 years post-onset, there was no evidence of aphasia.
Animal, voice, big, voice, trend, members, may now supportion the gestures and this the sick swallow over while the cats save stolen cookies from the kicker jaw on the.
All right. I think like the first patient, you'll agree, or the patient we just listened to, her phonetic or articulatory difficulties stand out. So let's quickly revisit the man we listened to at the outset. And I think you'll agree here that what dominates his speech pattern are his rate and prosodic difficulties.
To participate in research directed at speech problems.
His rate is slow and he's got considerable segmentation of syllables.
Research is to show that speech problems can occur in isolation of other neurological problems.
And one more sample. This is a 79-year-old woman who is 4 years post-onset of her speech difficulty. No evidence of aphasia on examination.
Aluminum.
What's the problem that you're having with producing speech?
It gets stuck. I have to pause to continue.
And you mentioned something about your muscles or the structures in your face before. What was it you said about that?
My tongue and lips won't cooperate with me to talk quickly.
So I think you'll agree that her primary difficulty is also stemming from problems with rate and prosody. It's very interesting when she says, I have to pause to continue. I would speculate she's telling us that she's able to program only a couple of syllables at a time. So what have we learned about this disorder? Basic demographic-wise, the age of onset is usually in the late 60s, but we've seen patients from their 30s to their 80s at time of onset. Gender distribution is relatively equal, although there's a tendency for this to occur in younger men and older women. Handedness is consistent with the population as a whole, possibly more non-right-handed individuals than might be expected. No clearly identified socioeconomic, educational, or environmental risk factors. The initial presentation of patients with this problem in tertiary care center settings is at about 2 to 3 years post-onset. The median survival of PPAOS is about 9 years, which is a little bit longer than it is for patients with progressive apraxia of speech and aphasia at the time of presentation, or progressive agrammatic aphasia without any associated apraxia of speech. The most frequent speech features include phonetic and prosodic abnormalities. So the list here is very similar to what you see on lists of characteristics of apraxia of speech in general. One feature that has not been noted in the stroke population with apraxia of speech is that a minority of our patients have reduced words per breath group relative to their maximum vowel duration. So some patients can prolong a vowel for 10 seconds or longer and yet only produce 2, 3, or 4 syllables on a single breath. And we speculate that the reason for that is related to their inability to program more syllables than that at a time. We have evidence to suggest that there are subtypes of PPAOS and progressive apraxia of speech. The phonetic subtype is predominated by articulatory or phonetic abnormalities, distortions, distorted substitutions, repeated sounds, attempts to self-correct. This tends to occur more frequently when aphasia is also present and when it is worse than the apraxia of speech. The prosodic variant is predominated by prosodic abnormalities, that is, segmentation of words and syllables and slow rate. The 2 patients you saw with predominant prosodic features are extreme examples. Most patients with the prosodic variant have more phonetic difficulties as well, but the prosodic features dominate. And the prosodic variant seems to be most evident in PPAOS, that is, no aphasia, or when the aphasia is worse than any, or when the apraxia is worse than any aphasia that may be present. And then there's a mixed variant in which there's no clear difference in the prominence of articulatory versus prosodic abnormalities. I will say that most patients progress to a mixed variant. So as they get worse, the distinction between phonetic and prosodic seems to blur. The distribution of subtype does seem related to whether a patient presents with PPAOS or whether they present with progressive apraxia of speech and agrammatic aphasia. So in the PPAOS group, the prosodic subtype dominates with 57% with a predominance of prosodic features. In patients with apraxia of speech and agrammatic aphasia, the phonetic subtype dominates. And when you look at patients whose apraxia of speech is greater than any aphasia, that breakdown is blurred a little bit, but is still maintained. However, when aphasia predominates over apraxia of speech, we see the phonetic variant predominating, and and basically in our cohort so far, no prosodic predominance in any patient. So the subtype distribution suggests that the phonetic features of progressive apraxia of speech may be more tightly aligned with aphasia or the language network than its prosodic features. And the prosodic features of progressive apraxia of speech are more easily separated from aphasia and perhaps more tightly aligned with the motor speech network. In terms of other deficits that might be present at initial evaluation in PPAOS, by definition, aphasia is absent early in the course. However, a fair number of patients will complain of substituting yes for no and vice versa and exhibit that behavior, even though there's no other evidence of anomia. And many patients will have reduced word or letter fluency, that is the ability to come up with word categories or words beginning with certain letters rapidly, even in the absence of other evidence of aphasia. About half of cases will have a nonverbal oral apraxia at initial evaluation, and that tends to be more frequent when aphasia is also present. Dysarthria seems to be present in about a third of patients at presentation. Dysphagia is usually not evident unless dysarthria is also present. Neuropsychological and neurobehavioral deficits are typically absent early in the disease course, and if there is any evidence of them, they are overwhelmed by the apraxia of speech. But motor, cognitive, and behavioral signs do tend to emerge over time, as you would expect in any or many neurodegenerative disorders. In our efforts to try to quantify the problems of patients with progressive apraxia of speech, we found that some simple acoustic measures of rate can really be quite helpful. So on the vertical axis here, we have syllables per second, and we have comparisons of control speakers, patients with agrammatic PPA who have no apraxia of speech, patients with the logopenic variant of PPA who typically don't have apraxia of speech but may make sound level errors or phonological errors. This group here is the combined three groups, controls, agrammatics, and logopenics, because there's no statistically significant differences among them. And then we have progressive apraxia of speech. So if you look at syllable rate per second for a simple one syllable word cat, there's no differences. But if you then increase length and complexity, so for the word catnip, or the word catapult, or the word catastrophe, or the word stethoscope, or sentence rate, you get a clear separation of PPAOS from those other groups. And this is a pretty robust finding with pretty good sensitivity and specificity. A pairwise variability index, which is essentially a measure of stress emphasis, also distinguishes PPAOS from agrammatic aphasia without apraxia of speech and control speakers. This goes along with segmentation of syllables. The PVI is not quite as robust as some of the other simpler rate measures. In trying to quantify differences by subtype, on the vertical axis here, we have the syllable rate per second for the word catastrophe. And on the horizontal axis, we have performance on a measure of articulatory errors, which is the percentage of articulatory errors made on a word and sentence imitation task. And what we find is that patients with the prosodic variant tend to be slower than patients with the phonetic variant, but not have so many articulatory errors, as opposed to patients with the phonetic dominant problem. Their rate is not as slow, but their frequency of articulatory errors is increased. So this may be one way to kind of quantify those two groups. We have more work to do on this. What are the neuroimaging correlates? Essentially, the primary composite abnormality is one of left greater than right superior lateral premotor cortex and supplementary motor area involvement. If you look at gray matter loss in this upper panel here, you can see involvement in the composite area. If you look at white matter loss, the areas involved are broadened somewhat, but generally still in the same general location. And if you look at PET findings, they correspond pretty closely to the pattern of gray matter loss. So this is more or less the signature of PPAOS. It's important to keep in mind that individual profiles can vary considerably, and they don't always match up with the group composite. So these are 12 patients, PETs, and just to give some examples, this patient, patient 8 here, has findings pretty consistent with the group. But we see patients when they present who have almost no abnormalities whatsoever. And we see other patients at the time of presentation who have much more widespread abnormalities, and occasionally see patients with right greater than left hemisphere predominance. So there's a fair amount of individual variability. So once again, if we look at PPAOS, this is very similar to the pattern of gray matter, white matter, and hypometabolism that we just looked at on the signature for PPAOS. If we compare that to patients who have progressive apraxia of speech and aphasia, in which the apraxia of speech predominates, the area of involvement is greater, and it moves a bit south toward Broca's area or inferior frontal lobe. And then if we look at patients with agrammatic PPA and apraxia of speech in which the aphasia predominates, the involvement is much more widespread. So the bottom line here is that PPAOS is essentially a much more focal problem than is progressive apraxia of speech with aphasia. In terms of subtypes and imaging, both the phonetic and prosodic subtypes share left premotor, especially supplementary motor area involvement. The phonetic subtype has somewhat more diffuse and bilateral involvement. The prosodic subtype is more focal, has more focal involvement in the SMA and right cerebellar peduncle. So in terms of just a summary of localization here, primary progressive apraxia of speech is a kind of superior premotor and supplementary motor area, and it kind of separates out from the different variants of primary progressive aphasia, including the non-fluent agrammatic variant. What about progression of PPAOS? Over time, as one might expect, the prominence and severity of the apraxia speech features increase, the phonetic articulatory errors increase, rate of syllable production decreases, and intelligibility declines. And here we have 3 measures that capture AOS severity. The horizontal axis here is disease duration. So these are profiles of 4 patients seen 4 to 6 times, 5 or 6 times at about yearly intervals. And on the apraxia of speech rating scale, which is a measure of the prominence and severity of 13 features of apraxia of speech, you see an increase in score over time, which means a worsening of apraxia of speech. On a measure of motor speech involvement, which is essentially an index of intelligibility, a 10-point scale, you see similar worsening of intelligibility over time. And on a simple 0 to 4 apraxia of speech severity rating, It's just a clinical judgment. You see deterioration over time. We also see deterioration on acoustic measures of rate. This is syllable rate per second for the word stethoscope. These are 7 patients illustrated here over 1 to 2 year intervals. The horizontal axis is years post-onset. So in general, we see a slowing of speech rate over time, although not in all patients. So we've got a couple of patients here who change little from 1 year to the next, relatively early post-onset. We also have patients who are longer post-onset who are not necessarily slowing rate more than some patients early post-onset. What this means is that it is somewhat difficult to make hard and fast predictions for individual patients about the rate of deterioration. In terms of other emerging clinical problems, aphasia emerges in 40 to 50% by about 5 years post-onset. The prevalence increases after 5 years, but aphasia onset can be delayed until 10 years post-onset. Dysarthria is evident in less than 30% of patients at 2 to 4 years post-onset. It tends to be evident in a majority of patients once they hit 5 to 6 years post-onset. And dysphagias usually not present until dysarthria emerges. In terms of other emerging clinical problems, in a group of 13 patients we followed from about 4 years post-onset to 7 years post-onset, none developed features of Alzheimer's disease. That's something we can generally tell patients early post-onset, is that this is not likely to evolve to the pathology of Alzheimer's disease. All of the patients developed extrapyramidal or Parkinsonian symptoms. Apraxia of speech remained the predominant problem in 62%, but 38% evolved to a severe progressive supranuclear palsy-like syndrome with all of the features that go along with PSP. So the conclusion here is that some patients rapidly evolved by about 5 years to a pretty devastating PSP-like syndrome, but others, maybe a majority, retain the PPAOS diagnosis, but with mild Parkinsonism at about 7 years. Some patients evolve to more of a cortical basal-like syndrome with asymmetric rigidity, limb apraxia, and other extrapyramidal features. And cortical basal syndrome seems to be more likely when aphasia is present and it predominates. This is just a tensor-based morphometry summary of neuroimaging changes. So on baseline here, the yellow and orange areas represent areas of involvement, and that follow-up 3 to 4 years later, we see much greater involvement. So neuroimaging evolves over time, although individuals may vary in their rate of progression. In terms of underlying pathology and histochemistry, autopsy data thus far suggests that PPAOS is very consistently associated with tau biochemistry or a 4-repeat tauopathy, which is usually consistent with progressive supranuclear palsy or cortical basal degeneration. In progressive apraxia of speech, when aphasia is also present, and the apraxia of speech is equal to or dominates over the aphasia, it predicts PSP or cortical basal pathology in a high percentage of patients as well. PSP or cortical basal degeneration or tau, 4R tau, is possible in PPA in patients who have no apraxia of speech or less severe apraxia of speech, but it's not common. And these findings thus far suggest that progressive apraxia of speech or PPAOS, agrammatic primary progressive aphasia, cortical basal syndrome, and PSP may represent different points on a single disease spectrum. So to begin to wind this up, what's the underlying disease mechanism of action here? And there is an what might be called a network degeneration hypothesis. And what this assumes is that neurodegenerative diseases, many neurodegenerative diseases, are not diffuse or random, and that the anatomy of the disease spread relates to some aspect of neural network biology, and that the root of disease progression reflects the brain's intrinsic functional network architecture. So the overarching hypothesis is that large-scale functional networks provide the scaffolding that's dismantled to produce different clinically recognizable syndromes. And essentially this means that the disease migrates through a functional network. There is evidence, in vivo and in vitro evidence, that demonstrates neuron-to-neuron propagation of tau aggregates. And neuroimaging has shown several neurodegenerative syndromes can cause circumscribed atrophy within functional connectivity networks. And there's actually some evidence for it in the agrammatic or nonfluent variant of PPA. So we can ask, is there any reason to believe that this may not be at work in progressive apraxia of speech? In other words, you have the onset and migration of a disease within and then through the motor speech planning and programming network. So, relative to stroke-induced apraxia of speech, PPAOS doesn't follow a vascular distribution, and it's progressive. So this suggests that some clinical manifestations between progressive apraxia of speech and stroke-induced apraxia of speech may differ, and that the components of the motor programming network that break down or are preserved might differ in some ways between them. Also, because PPAOS seems to predict underlying pathology, because it might reflect erosion of a functional network, the speech planning and programming network, and because it may have clinical subtypes, phonetic articulatory versus prosodic, that presumably reflect breakdowns at different stages or levels of motor programming. PPAOS may provide another opportunity to study the slow dissolution of programming with insights into the nature of apraxia of speech in general, or beyond what stroke has taught us, and about the relative vulnerability to disease of speech units like sounds and syllables and metrical units, and speech flow like rate and prosody, and the ways in which the speech programming mechanism responds from a neuroplasticity perspective to the gradual loss of its integrity. So if all of those hold, there seem to be implications here for models of speech motor control. So, for example, the functional network spread in PPAOS might help us better define the anatomic boundaries of network models. And the possibility of subtypes of progressive apraxia of speech suggests that the articulatory or phonetic aspects of speech production are to some degree dissociable from the prosodic aspects of speech production within the healthy brain and within diseased speech motor control networks. So models of speech production or speech breakdown may need to account for those possibilities. That's all I have to say formally. I provided some recommended reading for you to pursue if you like. And I'm happy to take any questions, recognizing that there may not be answers for them. Thank you.
Thank you very much, Joe. That's great. As always, the audience is clapping at home, so you can't hear them, but they are, believe me. The questions are flying in. So let me first go. I actually wrote down the first question, so let's not do that. So let's first go to a question from someone else. Asif Basha asks, how would you characterize PPAOS in terms of focal and or diffuse lesions or degeneration or hypoperfusion, which is not visible on neuroimaging? So basically, so can you talk about the things that we can't see on the scan?
Yeah, well, if you can only, I think, only characterize it by its clinical features, which are the predominant speech characteristics and any acoustic measures you might have to support that, or other physiologic measures if you have them. We have certainly seen patients who at presentation have unambiguous evidence of very mild progressive apraxia of speech, and who kind of give us proof of that as we follow them over time and their disorder blossoms, who have normal neuroimaging. So one can provide a clinical diagnosis, assuming neurology has ruled out the patient meeting or having other clinical deficits that would meet criteria for another neurological diagnosis. So if they have prominent falls and abnormal eye movements or asymmetric rigidity, they may meet criteria for corticobasal syndrome or progressive supranuclear palsy, in which case they would not get a diagnosis of primary progressive apraxia of speech. They would get a diagnosis of corticobasal degeneration or PSP with a prominent apraxia of speech. I hope that answers that question.
Thank you very much. Then we have a question from Maria Ivanova. Have you seen insular involvement in primary progressive AOS or POS? Damage specifically to the insula has been shown to lead to AOS and stroke.
Yes, and some of our patients do have involvement of the insula, and the ones who do tend to have more predominant phonetic or articulatory characteristics than predominant prosodic features. And I think other people might comment on this, that fits with our general impression that stroke-related apraxia of speech tends to be either mixed in its prosodic and articulatory features, or perhaps phonetic or articulatory predominant.
Yeah.
So the simple answer is yes, some do, but certainly not universally.
Thank you.
I can't give a percentage.
And that actually does relate also to a question I did have, which I posted also. So what is your primary reason for maintaining that prosodic PPAOS is not simply a less severe form of PPAOS than phonetic PPAOS?
Yeah, that's a very good question. One reason is that when we have looked at severity ratings between people with the prosodic and the phonetic variants that we've classified as such, the severity ratings don't differ as a group. So on the ASRS, for example, the composite score on the ASRS is not different between phonetic and prosodic patients. However, the prosodic features of the ASRS will be rated as more severe as the phonetic features, and the phonetic features as more severe as the prosodic features, but added together, there's equivalent severity. But that is a good question. We do see some patients with very subtle, who have very subtle deficits at presentation that we can't classify because it's just too subtle at the time. And we see, and don't forget that some patients are rated as mixed. This is not an either/or phenomena. A fair percentage are mixed, but it's a good question. If one rates, I will say, if one rates intelligibility, then the prosodic patients early on are not going to be as impaired as the phonetic patients, because the slow rate and segmentation of syllables does not impact intelligibility to a significant degree.
Thank you. Then we have a question from Kirana Tsapkini. If we label both prosodic and phonetic as PPAOS, don't we risk to enter into the present logical inconsistencies of the non-fluent variant PPA with AOS or syntactic deficits? If the anatomical differences are so different, why consider them together? What is the role? Okay, and then and after that is, what is the role of the insula that seems to be involved in AOS, which I think you've addressed.
Yeah, I can't address the role of the insula based on our findings thus far. The composite findings of superior premotor and supplementary motor area include all of the patients. So the phonetic, the prosodic, and mixed patients. So when we see the one problem we have is that when we look at some phonetic patients who are also aphasic and they have more involvement of inferior frontal lobe, my question is, how do we know that that migration south is just a reflection of the emergence of the aphasia and not related to anything that's going on with apraxia of speech, or it does? I don't think that we have a good way right now of parsing that out. And yeah, you do worry about the lumping and splitting issue, and one needs to be careful of that. But we've really been struck by some of these. The thing that put us onto these subtypes is the patients like the ones I presented here, who are very predominantly prosodic. And when I first started seeing those patients, I wasn't sure what they had, because they didn't have many of the traditional features of apraxia of speech that we usually associate with it. And it was only as they evolved to have a more full-blown picture of apraxia of speech that we began to say, gee, this is an early manifestation of how we usually think about apraxia of speech.
Yeah. Thank you. And a follow-up also related to the same topic is by Ariana Welch. Do you find that the phonetic and prosodic subtypes vary by underlying pathology? So that is PSP pathology more common in the patients with more distortions and CBD more common in the patients with more prosodic difficulties?
Yeah, I don't think we really have the answer to that yet. With the exception that, and we don't have enough pathology yet to really draw firm conclusions. But there is a tendency for patients who get a diagnosis of corticobasal syndrome by pathology to also be aphasic with greater aphasia than apraxia of speech. And to the degree that the ones with aphasia tend to have more phonetic dominance, there may be some predictability there, but I don't think our numbers are great enough overall, and I don't think we have enough pathology yet to be confident about that.
Thanks. We have a question from Julius Fredrickson. Have you ever seen a case of progressive AOS where the predominant neurodegeneration is in the right SMA?
Yes, we do have some patients where that is the case. I think I showed one individual patient's PET findings where there was clearly greater right than left hemisphere abnormality, including the SMA. So we have. And you know, there's something likely going on in the right SMA that is related to this problem. The left tends to predominate, but we have seen a right predominance in some patients. We've not yet carefully looked at the speech features and other findings of those patients versus the left predominant to get a handle on that. But it's a very good question, and really we need to look at that.
Thank you. Then we have a question from Kiriaki Neofitu. Is there any evidence that the disease progression might reflect the structural connectivity of the healthy brain rather than the functional connectivity?
That's a good question. I don't have a good answer for that. It's the normal connectivity that is the scaffolding for this problem. Another problem that one faces with a progressive disease is that presumably the features you are seeing are a product of the disorder itself, as well as the person's conscious or the network's subconscious efforts to compensate for the progressing difficulty. So matching the problem or attempts to compensate for it, either at a behavioral or functional network level, is challenging.
Maybe on a related note, I guess part of the question is also whether we know if the disease progresses via white matter tracts, for example, along those tracts, or is it irrespective of cell structure?
Yeah, and I think that there's good evidence that there's a lot of white matter tract involvement in these patients, and more in PPAOS than PAOS with aphasia. We do have data that suggests that. And more subcortical involvement as well.
Great, thanks. And I have a last question on the list, because you've answered a lot already. From Ariana Welch, again, regarding the lumping versus splitting question, should we aim for a label which reflects the quite significant contribution of dysarthria in this cohort?
Yeah, good. Again, it's a good question. The dysarthria is not typically present at presentation. So when we do our consensus meetings, we always address whether or not it is present. We always address whether what its type is, if it is present. I think it's a fair assumption that a dysarthria reflects the progression of disease beyond the strict boundaries of the planning and programming network into the execution network. Inevitably, these patients have bilateral involvement and typically have subcortical involvement. So the emergence of dysarthria is entirely expected. It's one reason why, at least in the prosodic and certainly the phonetic patients as well, the disease tends to evolve toward greater motor than cognitive problems. You know, as this disease progresses, you don't find patients having predominant neurocognitive problems that we might associate with Alzheimer's disease. What they migrate to are the clinical features of PSP and corticobasal degeneration, whose cardinal features are predominantly motor, although they can be associated with cognitive problems as well. So how dysarthria would fit in, I'm not quite sure. The types are typically spastic and hypokinetic. Relative to dysarthria, I'll also say we sometimes get very confused early on about whether we are seeing apraxia of speech or ataxic dysarthria. And that usually gets disambiguated over time as things evolve. But we sometimes see abnormalities in the cerebellum with our neuroimaging that makes us think about its role in the network that is breaking down.
Thank you. And I did mislead you somewhat by promising that that will be the last question, but we do have one final question that I think you may want to address. Lindsay Keeter says, great talk, thank you. Can you talk briefly about your management or treatment recommendations for PAOS subtypes?
Well, obviously, very briefly. I'd say a few things. Management and treatment is appropriate. Like many other degenerative speech and language disorders, just because it's degenerative does not mean it cannot be treated or managed. I think with this group of patients, one thing I would emphasize particularly early on is the importance of counseling. We see many patients with PPAOS who have been on a long diagnostic journey and who have been misdiagnosed. And considerable time needs to be spent in informing them and educating them about the nature of this problem and what it is not. And for example, many patients have come with a diagnosis of PPA. Well, we tell them that at least we distinguish PPA from PPAOS, and we discuss the differences. We also have enough data now to be able to discuss and counsel about the course of the condition, even though our predictions are not really good. But patients really, the counseling and the diagnosis is a key component to treatment. We do not have any good data to indicate that traditional treatments for apraxia of speech is effective in primary progressive apraxia of speech, but we do not have any data to indicate that it's ineffective. And particularly for patients who are progressing slowly, the standard apraxia of speech treatments that are used for patients who've had stroke-induced apraxia of speech may be quite appropriate for some patients for a considerable length of time. So I would say that standard treatments for apraxia of speech need to be thought about early on. The other important thing is that one needs to anticipate the probable need for augmentative and alternative means of communication as the condition progresses. What is tough is knowing whether that's a year down the road or 5 or 6 or 7 years down the road. And we're not quite wise enough yet to know who's who. Anticipating the need for AAC also needs to include consideration of the likely additional motor deficits that are likely to emerge. So these patients are going to develop limb control deficits in most cases, with obvious implications for the AAC system that is devised. And some will develop eye movement control deficits, which has implications for eye gaze technology. And so there are some challenges that lie ahead when one thinks about AAC. But formal treatment is appropriate. And anecdotally, we've seen patients who have reported benefiting from it.
Great. Thank you so much, Joe, for addressing all the questions. We've come to the end for today. We really appreciated you talking to us. Thanks for your work and thanks for sharing your knowledge today. there's many more comments in the chat box arriving now, thanking you for your talk. So I will share those with you if you don't see them now.
Well,
The recording of this lecture, as always, will be up probably in a few days. And thanks again, Joe, and thanks for the audience for sticking with us today. And then we hope to see you on October 29th.
well, and thank you, and thanks for the great questions.